Hi, everyone. My name is Sonal Shah. I am the Executive Director of the Beeck Center for Social Impact and Innovation at Georgetown University, and I get the pleasure of moderating. Is this the final panel? So I'm between you and drinks. Is that the point? Okay. We're going to pull this out as long as possible. But I'm very excited to be here and very excited that this book is being launched. And so first I want to congratulate Nonprofit Finance Fund and the Federal Reserve Bank of San Francisco for putting out the book, but more importantly, having this conversation around the nation on what it means to get to outcomes. I think too often, as you all know, we hear lots of terms, and it's nice to have the conversation around it. So we're very happy to be here. The final panel, and what we hope to do in this panel, is really drill down from the big level concepts to the great inspiring talks you heard, to really talking about what it takes to do pay for success and outcomes financing. Because it sounds theoretically great until you dig into it. And then you have to work through, what does it mean for your organization? What does it mean to partner? How do you think about this? And so today, we have the pleasure of working with an incredible, to talk to four incredible speakers, three of whom come from one of the most iconic organizations in the United States, Meals on Wheels. And how many of you have heard of them? Right? See, this is exactly. You can say Meals on Wheels and everybody nods. You say Beeck Center, people are like, so just to be clear, and so what's amazing is when you think about organizations like Meals on Wheels, you realize the network and the opportunity and the connections they have in communities across this country. They serve, if I am correct, approximately 1 million meals a day. And that's scale, right? I mean, we talk about scale, but that's talking at scale. And they're more than just about providing meals. They provide health and psychological benefits to seniors beyond just the basic nutrition that's delivered every day. And that's what we're going to talk a little bit about here, is how do they get to outcomes? How do they measure outcomes? How do they think about outcomes? So let me introduce our speakers, and then we'll go right into questions. And you will all get index cards, so please write your questions on index cards so we can rapidly go through them at the end, and we can make sure we have time for Q&A. Our first speaker, and let me just go through. We have Lucy Theilheimer. Did I say that right? Theilheimer. See, I should ask that question in advance. She is the Chief Strategy and Impact Officer at Meals on Wheels National. We have Stephanie Archer-Smith, which is right next to her on the left. She is the Executive Director of Meals on Wheels Central Maryland. And then we have Janice Benenson. And Janice is a volunteer on Meals on Wheels, and she's going to talk a little bit about her experience and why it matters. And as those of you in the nonprofit sector understand, you run multidimensional organizations, so it's not just about the service you provide, but those that are part of the service that you provide and what that means and how to integrate that and what that means also as a part of the outcomes that you achieve. And then finally, we have Dan Hale, who's at the end. He decided he needed to sit the farthest from all the women, who is the Director of Health and Community Partnerships at Johns Hopkins Bayview Hospital. And what's fascinating is having Johns Hopkins Bayview as a partner in this and how they're approaching this conversation. And what I hope you'll hear from him a little bit is a little bit of the, just not the skepticism, but the idea of, like, what did it take for Johns Hopkins Bayview to come into this conversation on measuring outcomes? So with that, I'm going to start with Lucy. If she can give us a little bit of an overview on, how Meals on Wheels nationally defines outcomes and how you are thinking about it from a national perspective and what it means, and why did you get to pay for success?
Thank you, Sonal, and thank you for inviting us here today. It's good to be here with you all today. So as Sonal said, I'm with Meals on Wheels America. So we are a national membership association, and we represent and support the almost 5,000 local programs across the country that are delivering those 1 million meals every day. So we do research, we do advocacy, education and training, program development, tools and resources, everything we can do to help those local programs do what they do every day, and to help them extend their reach and their impact. And as you can imagine, one of the challenges that these local programs face each and every day is securing the funds that they need to meet the demand that's growing every day as well. Federal funding represents a fraction of what's really needed out there, and they are fundraisers extraordinaire. They spend a lot of time out there trying to find that dollar so they can meet the need. And many programs have extensive waiting lists, and our goal is to try to enable programs to deliver services to all those who need them, and ideally to find sustainable revenue sources, quite frankly, right, to pay for the services that are so valued in the community. So we have been on a journey for more than 10 years to demonstrate the value of Meals on Wheels programs in several ways, one of which is in improving health outcomes, and the other is how that can be translated into saving money, particularly for the healthcare system. Tyler Norris was talking before about social determinants of health. We're a social determinant of health, right? Everything about nutrition. If you don't have nutrition, it's hard to have any kind of health. It's hard to recover from acute incidents, and clearly it is the one fundamental need that every senior in America should be able to have met. So we've been doing a great deal of research. We even did, I'm not sure where our colleague is from Urban Alliance, over here. We even did a 15-week RCT with Brown University. So we have been and we have slowly generated an evidence base that demonstrates the impact and the value of Meals on Wheels services, and to Sonal's point, the combination of that nutritious meal, the visit, to companionship, human connectedness, and doing safety checks in the home and remediating for barriers and safety hazards to hopefully reduce the rate of falls and the need for high-cost acute care services. So that's the mission we've been on, and we've had multiple strategies to do that. And we learned about Pay for Success and got very intrigued. Our CEO met one of the folks, I don't see where he's sitting right now, Eric Letzinger, there he is, Quantified Ventures. And this was before I arrived at Meals on Wheels America, and they got to talking, and they thought, this could be an interesting opportunity for a Pay for Success project. And so Quantified Ventures conducted a feasibility study for us. And out of that, we decided that this looked like something that could be a promising opportunity to further build that evidence base and demonstrate the true value. And when we talk about demonstrating the true value, we're talking first and foremost about the ability to reduce things like emergency room visits, 30-day readmissions, all-cause hospitalizations, length of stay. Those are the primary outcomes that we've been looking towards. But we also are looking at secondary outcomes like the ability to reduce rate of falls and the ability to manage medications more appropriately and things like that, so that we can continue to build that story about how valuable it is. Of course, our long-term goal in Pay for Success is that healthcare is going to see the light and begin to pay for these services so that we can serve all those in need. So that, I think, is sort of the big picture of how we got into this. Great. So I think I'll stop there.
Thank you, Lucy. Stephanie, you run a very localized version of Meals on Wheels in Central Maryland, and how do you think about your very specific outcomes? What are you trying to do? Lucy gave us a little bit of insight into what are some of the metrics that you're looking at in terms of reducing rates of falls, but reducing healthcare costs. Like, what are the things that you're looking at, and what does it mean to you, like when you hear about these information when it comes to you?
Sure. Well, first of all, Meals on Wheels of Central Maryland is one of those local programs, and we are working in our community every day and fundraising every day to be able to provide meals and a whole array of support services. And when I think about the outcomes and impact outcomes, what I think about is to what end are we doing these things? Nonprofits like to talk about big numbers, and we do that. So we say, in our annual report, you'll hear us say we served over 1 million meals a year, or we serve over 3,000 individuals in a year. But the challenge that I put toward my staff is to talk about to what end are we doing those things. And I think that end is defined in our mission. Our mission at Central Maryland is to keep people living independently at home. And so one of the things that we do is we look at how long are we able to sustain people living in their home. When someone comes on service to Meals on Wheels, we do an in-depth assessment that gives us insight into what their imminent risk of displacement is. And we continue to assess them annually, but periodically we also assess them through surveys. And that's one of the ways that we look at, how well are we doing? What percentage of those we serve are able to stay 6 months, 12 months, 24 months longer in their home because of our service. We have another service, a grocery assistance program, where we pair volunteers with people who may not need that home-delivered meal just yet, but they still need the support. They're still homebound. They still don't have access to proper nutrition. And in that program, there's lots of reasons why people don't eat healthy or their nutrition is compromised. And we're looking at two components or two reasons for that in that program. One is their access, and the other is their education around the understanding of nutrition and the importance of nutrition and health. And so when someone comes onto that program, we will do a survey around some of their behaviors. How frequently are they eating breakfast? How frequently do they consume fruits and vegetables? And we look at a baseline and we measure that based on their likelihood to do it. And then what we do is we do quarterly surveys to see how that needle is moving for that individual. And of course, with this project that we're working on, we have very specific outcomes around acute care utilization and around disease management and health literacy. So those are some of the examples of what we're doing. And admittedly, some of them may be imperfect, self-reports, but I think it's an important beginning. It's what really has led us to this other project and the more scientific, I'll say, randomized controlled trial.
As I'm listening to you, I'm thinking there's so much data that you're collecting on a regular basis, and I think there was somebody up here earlier on the stage who talked about how much data they were collecting and how important that was. It's just a good reminder, organizations collect a lot of data. We may not call it valuable or know why it's valuable, but there's a lot of data out there that we should be thinking about, and you're collecting it and looking at it, even if it might not be in a randomized controlled trial, but you're understanding that data and using it effectively. So we'll talk a little bit more about it with Dan and all of you in a minute. Janice, it is such a pleasure to have you here. You are a volunteer with Meals on Wheels Central Maryland, and maybe you can tell us a little bit about why you got started, how you got started, and what have you learned both about yourself and your clients?
Thank you. I retired about 3 years ago after a 50-year work life in the for-profit sector. And when I retired, I wanted to do some volunteer work in an area that would be meaningful and where what I did would be meaningful and appreciated. And I mentioned this to a neighbor of mine who had been a volunteer with Meals on Wheels for 20 years. And that is not an unusual length of time. When I go to meetings with other volunteers and we go around the table and people say they've been a volunteer for 8 years or 14 years or 20 some odd years, and an 85-year-old who's moving said, I'm sorry to leave, but when I move, I'm going to, deliver Meals on Wheels in my new location. So this is because it is meaningful to us. And I didn't know anything about it, but I started as a ride-along with my neighbor and very quickly became hooked. And now I have my own route, and I have been doing it the same route with basically the same 9 clients that I see once a week. And there is a benefit to that because we get to know each other and we get to see each other, and it is so much more than delivering the meal, which is vital to them, but I see it in the gratitude that is so genuine and expressed every single week as I deliver these meals. And some people don't want to talk to me at all, very few, but some. They just want to take the meal And that's their privilege and that's their dignity, because this is what's keeping them in their home. But I'm very aware that for a lot of elderly people, they're invisible. And I may be the only person that they get to see or talk to that day. So I personally make an effort to engage with them to the degree that they want to. And I have one client who is 93 years old, and he's basically immobile. He can't get up to answer the door. He's in a chair, not a wheelchair, but a chair when I get there. And the door's open, and I tell him, I always knock and say, Meals on Wheels, and he says, come on in. And I come in and I leave the food, and then we chat. And I had a great sense that he was very lonely. And so I chat longer. And I mentioned to him that Meals on Wheels doesn't just deliver the meals, but we have a program called a phone pal who could call and talk to them at any time. We have people who come and will sit and talk to the clients and maybe read a book or whatever. And he said he would think about that, but he liked talking to me. And one day, which is fine, we have great conversations. You can tell from his front yard, he used to be a great gardener. And I talked to him about his plants. And I sensed, as I said, this sense of loneliness. So we talk, and he always says to me at the end of my visit, which isn't that long, he says, "You've just made my day." So making his day is more than just bringing him food, although that he needs as well. He clearly can't get up and prepare his own food. And so that's one of the things that's meaningful to me. There's also that continuity that I get to see the clients on a regular basis, and if something is wrong, I get to see that something's wrong. I did have, for a brief period of time, a client who would answer the door. He would joke with me. I was afraid of his cat. We joked about that. It's a strange fear, I know, but a couple of times, I went a couple of weeks in a row, and he was really filthy. It wasn't normal. And I came back and reported that to Meals on Wheels, I have a chance to write it on the client form, and I verbalized it. And within 2 weeks, it turns out he was hospitalized. I don't know what the problem was, but I don't know that anybody else ever saw him or would have known. So he was kind of saved medically in a sense. I don't know that I saved his life or anything, but he was. And I'm just very aware that there is a social aspect to this, but there's also a gratitude on the part of the client. I think they understand that food is a caring thing, and it starts with the people preparing it in the kitchen to those of us delivering it, and they are appreciative that somebody cares about them. I have a lot of clients in their 90s. Their children are far away. Their neighbors have disappointed them. There's one woman who, in the beginning, when I went to talk to her, she answered the door. We have a routine that we developed. She's extremely hard of hearing. Meals on Wheels tells me that. They say, knock hard on the door. That didn't work. But she wears her phone, I noticed, around her neck. So when I pull up into her driveway, I call her because it's going to vibrate. And she hears it, and I say, I'm in the driveway. She says, I'll open the door. And in the beginning, she wore a hat all the time. She was very wrapped up. And I would give her the food. And over time, I noticed that the hat has come off. But she gives me a weather report every day. She's like, that's her job, you know. And I'm very interested. You know, she tells me, I listen carefully, you know, and she seems to have gotten stronger or at least more comfortable with me. And there's a different person every day, and each of us has a different relationship with the different clients. But I do know it means a lot to them. So, I've been on vacation for 3 weeks, and tomorrow's my day. And I can't wait to go back and see my clients and see how they're doing. So it's been a great program to work with, and I have done something that is meaningful, and I feel like I make a difference. So.
Thank you. These stories also just bring to life organizations, so thank you for that. And more importantly, it's really interesting just listening to just both the trust you're building and the responsibility you're feeling at the same time. And it's so important because it's not just about what we get out of it, but what responsibility we take as a part of it. So I appreciate the story. Dan, you know, you've worked at this from a hospital perspective, right? You see clients as they come into the hospital for services. And here you're working with Meals on Wheels. Maybe you can tell us a little bit about the partnership you're building, why you came to this, and how you thought about it. Because if I remember correctly, even from our conversation in advance, you had never even heard of the term pay for success.
Correct.
Prior to any of this.
Correct. And most of my colleagues at Hopkins still haven't heard of it, unless I talk to them. So let me say a couple things about where I work. Johns Hopkins Bayview Medical Center is where the Division of Geriatric Medicine is based at Johns Hopkins. And our president, Rick Bennett, is a geriatrician. So we're very attuned to some of the challenges we face with an aging society. And one of those that comes along with an aging society is really a chronic disease epidemic. And when you think about that, certainly medical institutions will continue to be important. Medical professionals will as well. But it's clear that most of the responsibility for monitoring and managing those conditions rests with patients. And they need support. And we need to find ways to be in touch with them. I mean, it's what happens in our clinics and the hospital is important, but what happens at home is so important. So we're very open to partnerships, but budgets are still tight. And so when we're approached or the idea comes forward about a partnership, we have to be working so that the programs are truly aligned. And so the initial skepticism may sound funny why I was initially skeptical. It sounded too good to be true. It's sort of like, you know, they didn't say it this way, but when somebody says, such a deal we have for you, you know, you're going to be very cautious. But so certainly you've heard about the three basic services that make so much sense. The nutritious meals, the socialization, the home safety checks. But also you heard about that feedback loop so that you could really be an early warning signal for us. So when our clinical director first heard about this, she was like, why haven't we been doing this for years? It makes so much sense. Of course, the problem is finances. And so when they're saying, you know, we have this idea, we're not asking for any upfront money. In fact, we're not asking for any of your money unless we achieve agreed upon outcomes. And so, and that sort of was music to our ears. That sort of got them in the door. The second thing I'll go ahead and mention is that Stephanie and I were already working on another initiative together. So the national organization, the local organization, Stephanie have tremendous credibility. So it made it easy to begin talking about this.
And would you mind giving us a little bit on what it is that you're doing together? And Stephanie, maybe you can give us a little bit in terms of how you're coming at the table with partnering with Johns Hopkins, and Dan, a little bit from your perspective of what that is. Why don't you start, Stephanie?
Sure. So one of the things that Janice described to you in one of her stories is a feedback system that we have called the Client Concerns Form. And that is when she noticed her client that she was delivering to who looked different, and she brought that back to the staff at Meals on Wheels, who then do a home visit and determine what next steps need to happen. So we used that model to talk with Dan and the partners at Johns Hopkins to say we can help be that bridge, the communication, to bridge that communication. We have been doing that with our volunteers for years, and when we actually started talking to our staff about it, they said, so basically what you want us to do is what we've always been doing. I said, yes, that's what we're going to do is what we've always been doing, but we're going to do it in a more formal way. And so we're developing an electronic survey that has volunteers respond to very specific questions about the condition of the home and the client status, and also asks about 5 key questions of the volunteer, of the client, and that's where the disease management comes in, and the management of those chronic conditions, and that information will be compiled and shared with the primary care physician. And that service, in addition, of course, to the meals, which is one of our core.
And Dan, how are you approaching this?
So we have high needs patients, those that come back more often than they or we would hope. And so the idea, can we identify those? And that's one of the things we had to work through, and it's been an ongoing process. I think where we are is 2 hospitalizations in the prior year, or 1 hospitalization and 2 ED visits. And so working with our social work department and our case managers, we can identify those, we can offer them this service, which I think of as sort of an enhanced, the same basic services, but somewhat enhanced. And they can be followed for 6 months. So I think most of any of you know healthcare, it's always, they're talking about 30 days, right? And it's sort of like a lot of services from the hospital, and then there's like a cliff you fall off, or there's a voltage drop, as some talk about it. When that's really, the 30 days is pretty arbitrary, really. So the idea that we could have some continued connection for 6 months is just, it's ideal.
It's a continuum of care, I think, that I've heard the other groups talk about too. Let me maybe more specifically tell us what the pay for success is that you're looking at. What's the size of the group that you're working with, and then what outcomes are you being measured on?
Together, we have worked to define the primary outcomes. And as I said earlier, they are primarily reduction in ED visits, 30-day readmits to the hospital, and overall all-cause hospitalizations and length of stay in the hospital. Those are the primary outcomes on which the payments in a pay-for-success project would be made. They're not the only outcomes that we are tracking. We are planning to serve 600 additional clients over the course of 3 years is the framework that we're working with. We are still working to zone in on our target population. We did start looking at some particular needs that Johns Hopkins Bayview had. So COPD, CHF, diabetes, hypertension were 4 specific disease categories that they wanted us to look at because they were frequent users of services, and they thought there was an opportunity to better serve those individuals in the community. And we are planning a 6-month visit with the core services that Stephanie described, and I think the enhancement is around care management, some additional care management services, and some additional in-home safety services. So Central Maryland has capability to deliver some home repair services, and if there's something that's more substantial, then they'll refer out to someone else. So it is a bit more enhanced. The other piece of the enhancement is this actual survey process. So Stephanie described the volunteer survey. That information, every client, every one of these 600 will have a care manager assigned to them, and those reports from the volunteer will go to that care manager to follow up and to see what kind of steps are necessary. And that is an enhancement to the current program.
So one final question, and then I'm going to go to questions from the audience. How long did it take from your perspective at Meals on Wheels to get to Pay for Success, and how long before you could build the partnership? What's the time frames we're talking about?
Okay, so we started the feasibility study in the fall of 2014, completed that early 2015, decided to move forward at that point. Is that right, 2015? Right. It feels like it takes longer than you think is the bottom line message. It takes longer than you think. So we actually started doing some work and starting to explore what kind of payers we wanted to talk about, and how were we going to identify programs that we might want to work with on this. It was actually during that time that the Nonprofit Finance Fund put out an RFP. And while I would acknowledge that I wasn't quite sure we were so ready at that point, we went into fast-forward mode, and we were successful in securing a grant from them that's helping to pay for the transaction structuring. So we began immediately we went through a process where we had about 4 or 5 candidate Meals on Wheels programs. We had defined criteria that we were looking for, and we did webinars and conversations with them, and in the end, we ended up selecting Meals on Wheels of Central Maryland, and Stephanie can certainly speak to what that was like from her side of the equation. And then we started to reach out to potential payers, and as Dan indicated, Stephanie and there was already a relationship there, and so we started to have conversations with Dr. Bennett, the president of Bayview, and Dr. Hale, and they were very supportive. And so that we signed an MOU towards the end of that year, in the fall of that year, and we have been working on developing the project ever since. So, and we have not. Our initial plan was we would have been in launch in January of this year, and we were not. So.
No, I mean, it's important to know, and I think it's important to recognize that it takes some time, and
Right.
it takes time for both of you to know that the outcomes are the same that you're looking at, and there's no clarity on what one is expecting, what the other is delivering, and to make sure that.
So I was going to add one thing. So it was helpful for me to go to an earlier Pay for Success conference this year, and to hear others talk about near-death experiences. Because there are a lot of challenges, and you just have it, but with commitment on both sides, and a little creativity, innovation.
Right.
But there were just discouraging moments.
Yes.
Everybody, remember, there will be discouraging moments, but you can work through them. Questions?
I've got them here.
Okay.
Okay, I'm going to give you 3 at once. First question, why is Meals on Wheels doing this? What are the primary benefits for you? On the contrary, what are the greatest challenges? The second question, what have been the biggest pain points you've encountered with Pay for Success? So perhaps similar.
I guess I'll take.
And then the
Pain
third
points.
question, what are the costs, financial and otherwise, for both sides, Meals on Wheels and Johns Hopkins, for participating in this program?
I guess I'll go ahead and start that. Why are we doing this? Our long-term goal is to secure sustained funding sources for these services at the local level. I mean, that is why we're in this, and we have multiple strategies as an organization to attempt to get these kinds of services covered, paid for at the community level. That's why we're in it, is to serve as many seniors as possible. There are challenges. There absolutely are challenges. There's also been remarkable benefits. I mean, the team at Hopkins Bayview is an amazing team of clinicians and professionals, and have been a joy to work with. One of the clinicians, who's a pulmonologist, has given countless hours in helping us to find the intervention and to work with us. And he is one busy man. I mean, he participates in conference calls after 2 nights of being on duty. I mean, it's just amazing how much commitment. I think the biggest challenge is that that we have faced was getting the data that we needed in a timely way through the Johns Hopkins Bayview system. In part, we're sort of at the bottom of the pile because we're not paying for our asks inside to get the data. And it took some time. There was some confusion because we were working through intermediaries. So what we were asking for, we didn't quite get. We had to go back a few times. And so that's been a challenge so that we could really zone in on the target population. And having that data impacts a lot of things like the evaluation design. So our evaluation design got delayed as well. So that's been the single biggest challenge. The other challenges, and I'll let Dan speak to it, is the process of translating the reduction in ED visits or hospitalizations, should we achieve them, into tangible savings for Bayview. So that was the other challenge. The last thing I'll say before Dan talks on that is, what does it cost? It costs a significant amount of money to do this. There are hard costs, and there's a lot of staff time involved. So I would say that between $250,000 and $500,000 for a total all-in cost, and that includes staff time, that includes evaluators, that includes ultimately lawyers for legal contracts. It includes a lot of elements of the project. But it is not an inexpensive venture, and quite frankly, I think it's one of the barriers to getting these projects off the ground, is that these costs, these are substantial projects, and they take a lot of time and money.
And Lucy, if I could just add something about the cost, what that doesn't include are some of the costs to the local program. Then you heard this earlier about scaling your resources and staffing up. So in order for me to be available, and for the other staff that are as available as they are to this project, we needed to think about what other things did we need in place. They're sort of secondary costs, I guess.
So Lucy already mentioned one of the pain points of the data, which was a difficult challenge for us. Another is just getting the right people in the room at the right time, because on something like this, you have to make sure you've got the clinicians on board, you've got the administrators on board, and you have the finance people on board. And to get them all in the room at the same time. And the most time you're going to have with them is 60 minutes. We just don't have meetings longer than 60 minutes. So when, whether it's Lucy and Stephanie or Eric and Brendan, it's like you got 60 minutes to talk to the president, to talk to the clinician, and to talk to the finance person and make your case. So you better really be on target and move quickly. The cost have basically been labor. We're an academic medical center, so we have young, energetic physicians and other clinicians who are eager to take on challenges. And of course, the hope is that, we do this the first time and we demonstrate through an RCT that it makes sense, and others don't have to invest that time. Yeah.
I'm going to do that with every one of my meetings, 60 minutes. Next 3 questions.
Okay, great. So what would you do differently if you had to do it all over again? This is a longer question. Given Meals on Wheels' name and its association with your program's outputs, not outcomes, how do you ensure potential pay-for-success partners, funders, and governments look past the outputs into the outcomes of the program? And the final question, what are the characteristics of readiness to take part in pay-for-success financing?
So can I just modify the first question slightly, just to say, not only what would you do differently, but what did you wish you had known before you got in?
So I was actually asked this question not too long ago about what I would do differently, and certainly there are things I wish I would have known. I mean, I had familiarity in the medical system. I had worked in a hospital before, so terminology and things like that were familiar, but certainly it would be nice to have known some very specific things about the different target population that we were looking at, but I'm not sure that I would have done it differently. There were pain points along the way, but we've learned so much, and I think a lot of the enhancement of what we're doing is the fact that now we have this incredibly rich base of knowledge that we've used to create a survey that we can use for this project, or we can apply organization-wide to our work. So I don't think I would have done it differently.
Moving from being seen as an outputs organization to an outcomes organization.
There we Yeah. Well, I think that is the journey that we have been on, and why we've invested so heavily in research, is to tell the story in terms of outcomes. So in the RCT, which our RCT also was self-reported data, but here are clients telling us that they feel that their health is better, that they feel that their mental health is better, that they don't feel as isolated and depressed, that they feel more confident in their ability to stay in their own homes. We are doing other research that's looking at the actual impact on use of acute care services. So we are doing everything to tell the story of, we deliver the meals, but it's so much more. It's really oftentimes the thing that stands between them being able to stay in their homes or having to go to a setting that they're not wanting to do. We talk about the meal as being the entree to many other things. I think it's just repeated communications, lots of marketing. We have an ad council campaign right now, which I don't know if any of you have seen. It's a really vibrant campaign, really trying to really focus on the seniors and who they are and how their lives are benefiting from what we do, not on the delivery of the meal itself as a product.
And the final question is on characteristics, but I don't remember the whole question, so I apologize.
So what are the characteristics of readiness to take part in Pay for Success financing?
That's an interesting question. Well, I do think that it's important to be able to have a strong evidence base. I'm not sure that we would have gotten much headway with Dr. Bennett or Dr. Hale if we hadn't been able to demonstrate through some of the research that we'd done that we believed we had an impact and could do something of value for them. So I think that was important. I think patience. I think you have to realize that it's a long haul, and if you're going into it, that you're willing to stay the course. This didn't turn out in terms of timing as we had planned, but we haven't given up. We've just, every time something's come up, we've learned something new, and we figure out how to get to the next place. And I think you have to be willing to be in this for the long haul. And I think it does take certain expertise. I think the benefit that we've had in the partnership is what makes it all work. Meals on Wheels America couldn't do this without Meals on Wheels of Central Maryland. We couldn't do it without the expertise that Quantified Ventures brings to the table about these kinds of projects and how to get them off the ground, nor could we do it without truly understanding the needs of the healthcare provider and what we need to be able to deliver in order to make it valuable for them.
Dan, do you have specific comments on this?
No, I think in terms of the readiness of the organization, she did a good job. They did a good job on that. How many are not familiar with the Maryland reimbursement system? Are there a number from not? Okay. So Maryland's has sort of made a move away from volume-based reimbursement toward value-based reimbursement through what's known as GBR, or Global Budget Revenue. So we know what our budget's going to be, so that's an advantage. So the possibility that we could prevent these admissions sounds good. What we have learned, this is one of the challenges we faced recently, is even with the RCT, if we demonstrate for the intervention group that there are fewer hospitalizations, we don't necessarily, those savings don't necessarily show up on our budget. So the savings might be somewhere else. And I know this has it's been one of the stumbling blocks with some other Pay for Success programs, because Medicaid will take all the savings. Somebody else does. And so that's something we still have to work on, is how can we, make sure that the savings do come back to us so we can reimburse the investor.
The wrong pockets problem is a big problem in terms of making sure that it gets quantified and those that actually are implementing the programs that get that. It's an important question. It's an important policy question, actually, to think about how to rethink the system, that the savings, just because the way we do it right now doesn't mean that's the way we should be doing it. I believe we are out of time. I want to first thank Janice. Your ability to make it real makes us appreciate the rest of this conversation, because it makes it understandable as to why you're doing it, but also what you've learned, and the stories you gave also helped us understand how Meals on Wheels works and why this pay for success is important.
Thank you. I feel like I get more out of it, so.
Well, if anything, you've convinced us all that we should be volunteering with Meals on Wheels. I was like, sign me up. It's important. And to Stephanie and Lucy, kudos to both of you for coming into this. I know this is not an easy thing, easy process. We talk about outcomes, but when you actually think about the length of time and think about how you operate and how you have to think about your operations differently in order to achieve the outcomes with a payor, it's an important process. So kudos to both of you for taking this on. And Dan, thank you for the perspectives on how also from the other side, the investor or the outcomes payor is also thinking about this, because too often we get one side or the other and we don't actually think about it from both sides and what the challenges are, both from a language perspective, who's in the room perspective, and are we all talking about the same thing? And how do we think about that? And then there's this broader question, and I think we all need to think about, which is what's the policy aspect of this, right? Who's paying? Where is this coming from? Is it Medicare? Is it Medicaid? Is it the government? Is it somewhere else? Because all of us are just pieces of a bigger pie, and where are those other levers that need to be changed? But I hope what you got out of today, at least from this panel, is a little bit of just how it works from an organizational perspective to make this work. And again, thank you to Nonprofit Finance Fund and the San Francisco Fed for doing this, because in these shifts, it takes time and energy, and it's important to have these conversations. So thank you.